For this frontal chest radiograph, we have a skeletally mature patient with a large, well-defined opacity in the right lower zone. The lesion has a thick wall with clear evidence of central cavitation. The internal margins are irregular, and there's an impression of an air fluid level within the cavity, which raises a few important considerations. The first question that comes to mind is whether there is any sign of bone involvement or destruction, something that can often suggest malignancy. However, in this case, no bony destruction is visible. The mediastinum and the remaining lungs do not show any other focal lesions, and both HeLa appear normal without enlargement. There's some airspace opacification medial to the lesion, which could indicate associated consolidation. Now, based on the lesion's appearance, a thick-walled cavity with irregular margins, the first differential to consider would be a cavitating lung malignancy, particularly squamous cell carcinoma, which is well known for this kind of appearance. This is especially concerning if the patient has a smoking history or risk factors. Bronchogenic carcinoma is at the top of the differential, but it's crucial to consider the broader differential for a cavitating lung lesion. Infective causes, such as necrotizing pneumonia or a lung abscess, can also cause cavitary lesions, although the presentation here, with a thick wall and irregular margins, is more suggestive of malignancy rather than infection. In terms of further investigation, it's vital to perform a contrast-enhanced CT scan of the chest to evaluate the lesion more thoroughly and assess for any mediastinal involvement or other nodal disease that could guide the diagnosis and staging. Bronchoscopy with biopsy of the lesion would be the next logical step, especially to confirm malignancy and allow for histopathological analysis. Now, examiners may ask, what about the possibility of infection causing this appearance? That's a valid question, and infection must remain on the differential, especially if the patient has a history of recurrent pneumonias or immunosuppression. A mesotoma can form in a cavitated lesion, and infections such as tuberculosis, TB, or fungal infections like aspergillosis can also produce cavitating lung lesions. However, the thick wall and irregular margins in this case push malignancy higher up the list compared to these infectious causes. An air crescent sign can sometimes be seen with infections, especially fungal infections, but in this case, it would seem more consistent with a malignant process. The clinical history would help guide this, especially in the context of TB or immunocompromised states. In summary, with the cavitation and thick wall, I would raise concern for a primary bronchogenic carcinoma, likely squamous cell carcinoma. As mentioned earlier, a referral for urgent bronchoscopy and biopsy would be necessary to confirm the diagnosis, along with staging CT to assess the extent of disease. Further down the differential would be necrotizing pneumonia or a fungal infection, but given the radiological appearance, malignancy is the most likely diagnosis here. For those of you watching, don't forget to subscribe to Radiology Made Easy and comment below if you have any interesting cases you've come across. Let's continue to learn radiology together. Sharp knowledge in less time.